Good morning, good afternoon, and good evening to everyone, depending on where you're joining us from. Welcome to GETSA's webinar, Myth Busting on ENFit Enteral Feeding Connectors. My name is Natalie Bigler. I'm GETSA's PR and Marketing Manager, and will be your moderator for this webinar. First, we'd like to introduce Mike Cusack, Executive Director of GETSA.
Thank you, Natalie, and good day to everyone. Thanks for joining us. I appreciate your time and attention. We're here today to talk about myth busting, and really what we'd like to do is share some facts and data with you regarding the ENFit connector since its launch over several years ago, and then then answer some questions later on. So Natalie, would you advance a slide? So hospital patients are surrounded by technology. If a hospital patient is in the hospital for more than 3 days, it's likely that they've come into contact or may be connected with up to 14 different devices. Historically, many of these devices rely on the same type of connector. That's the lure connector. The Emergency Care Research Institute found enteral misconnections in the top 10 technology hazards, and that led to the International Standards Organization convening a worldwide group to establish standards for small bore connectors to function as a system of independent, mutually incompatible connectors. We're here today to talk about the ENFit connector, but also on the market is the NRFit connector, which is used for regional anesthesia. The standard for the respiratory connector has been approved, and that will be coming out in a matter of months. So over the past several years, ENFit's been successfully adopted in countries around the world. However, during the course of that adoption, there have been myths that have popped up. These misperceptions are what we're going to talk to you about today and to provide you with some facts and data to help set the record straight. Next slide.
Thank you, Mike. I'd now like to introduce Chris Filato, Clinical Manager, Pediatric Pharmacy at UNC Children's Hospital.
Thanks, Natalie. So before we get started, I guess one of the things I want to do is just sort of give folks a little bit about my background and where I'm coming from here. So my whole career has been in pediatrics, including stops at some noteworthy institutions like Texas Children's Hospital, Children's of Pittsburgh, Johns Hopkins Children's Hospital before arriving here at UNC. So when a lot of this all started with moving towards the push to move towards ENFit, I was pretty engaged at each of those institutions, including places like here in Johns Hopkins that, really are children's hospitals within larger adult hospitals, concerned about the pediatric and very much the neonatal perspective. And could we figure out a way to make sure that we could use this new technology and this new connection that we were going to have in a safe and effective manner? So the first myth that I'm going to talk about, next slide, please, is specifically for the neonatal patient population and also some other children as well. We were worried very much, could ENFit accurately deliver low doses, small doses to patients? And there were a number of different iterations that came out in the time. And I know I had been working with different manufacturers, and every time we saw a new version, it was a little bit better and a little bit better, and nothing quite got there. And then we found the low-dose tip syringe. And when this came out, now a myth has popped up that it is not accurate enough for use in our NICU patient population, where small variations in dosing accuracy can be very important. Next slide. So when we finally came across the low-dose tip syringe, it wasn't just key stakeholders like myself, but we also involved some of the governing bodies or the professional organizations we have that really are standard bearers for safety in ISP, ISMP, ASHP from a hospital pharmacy perspective, and then ASPIN from a nutrition perspective. And each of these organizations, as well as I mentioned, a lot of key stakeholders, were all involved in the design where we got here. Next slide, please. So during that development process, one of the things, the main piece that we were really concerned about here was when we made the syringe a female connection, this cup at the end that had a significant amount of volume, and if we were to give this orally as opposed to through a tube or even via tube, was that cup that we had on the end going to be too clinically significant to be accurate? And what we really came up with the low-dose tip syringe is almost using the old technology, the legacy syringes that we have, and you can almost see it embedded right here inside the tip, or then in this alternate drawing picture, how we've got a tip inside, but then took the existing, what we've been using for dozens of years, and then make it ENFit compatible by putting this cup on to make sure that we were eliminating the possibility of the connection errors, which was the goal of this, but doing it in a way where we can make sure that we were just as accurate as the current syringes that we had on the market. And we think that we've really done well with coming up with this low-dose tip syringe. Internationally, it's been used millions of times. So we've been able to get some data to prove that over 120 million of these syringes has been sold internationally. So it may be something that is new to us here in the US and that we're still adapting to, but internationally, it's just kind of become the basic standard, and we need to get to the same place here at the US. What we've really been able to determine is that what we've got is very accurate. So how did we determine that? Next slide, please. So this is not something that we wanted to necessarily just take the word of manufacturers or even just the experience of others, but we did look at using a third-party lab. So we had outside vendors do an analysis to make sure that what we were delivering was as accurately as possible. And what we found was it is equally accurate with our legacy syringes, and some of the other technologies like the reverse lure system that have come out, it's actually been outperforming those. The main piece that we're really worried about here is often comes to do with when we're giving these syringes orally versus, which is likely to happen, especially on an outpatient side where we use them interchangeably. And were we going to have any issues with the moat or that area? And actually, if we go back one slide to the picture, that area in between the tip and then the cup that we have here, and was this going to get filled with drug and then lead to someone accidentally or unintentionally ingesting that additional drug volume and therefore leading to an overdose? So if we can advance it again, what we have found though is, one, in clinical practice, we haven't seen there to be an issue. Between the international doses and also a number of places, which we'll show here in a moment, that have utilized this, we have not seen any clinically significant difference between what we were seeing with legacy syringes or what we are seeing or what we're seeing with the ENFit syringe. Additionally, if those experiences make you still feel uncomfortable, there are adapters. So those adapters, whether they are, and straws are one of the most common ones we see though, really eliminate that dead space altogether and allow you to be able to give that oral dose without there being any issue. And if there's still some concern, it's a common practice and has been again for decades now, that when we have, say, air bubbles in a syringe, whether that's an oral syringe or even an IV syringe, to be able to flick those out, we can clear the moat the same way that we would clear out those bubbles within the barrel of the syringe, just by flicking the outside so that we can keep it only within the syringe proper and not have anything in the moat at all. Next slide. So as I mentioned, besides what's happening internationally, there are a number of places, and you can see a lot of them are in California, but then there are also places like Akron in Ohio or here at UNC who have already made this conversion. So there's a number of leading children's hospitals that have already fully converted and have been doing it for quite some time. UNC has been on ENFit for almost 3 years now without seeing any significant effect. So we've got both the data from our third-party vendors, we've got international data, and then we've got a lot of local users here as well in the US that are really all doing the same type of analysis and have all had come to the same conclusion, which is the low-tip syringe really works well. Next slide, please. Now, there's been a recent communication that has come out where the FDA has put out a warning specifically regarding these syringes, and that has given a lot of people pause because there was the words warning and FDA in the same sentence here. Important pieces that can get lost considering if you look at even just the screenshots of how long these alerts are, that this was just basically an awareness alert. There have been no reports of overdose, no reports of injuries, just concerns about the theory of if something could go wrong here. So Then as a result of that, they sent this out. However, they also still send out the recommendation to use ENFit syringes, including the low-dose tip syringes. And I think that those are really important things to make sure that we are emphasizing that the FDA did send out a warning to make sure they're being transparent with the fact that there are concerns out there, but that we haven't seen any actual harm. Next slide. Which brings us to the conclusion, which is these are good. They're safe, they're tested, and we feel very comfortable, and that includes the FDA continuing with the recommendation that this is a direction that you should go, and that includes for your pediatric patient population and your NICU population.
Thank you, Chris. We'd now like to introduce Barbara Fleming, Clinical Nurse Specialist, NICU at Ann and Roberts H. Lurie Children's Hospital in Chicago.
Thank you, Natalie. My relevant background is that I am the clinical champion for our pediatric hospital's conversion to ENFit in 2017, and it was viewed as a patient safety initiative to prevent misconnections. So I'm here to discuss myth number 2. ENFit's design does not allow venting and draining that is needed to fully convert facilities and support the home feeding experience. Next slide. So feeding tubes are designed to feed, and they are subject to the ISO standard for ENFit connectors. And decompression tubes are intended to drain and vent and are not intended for feeding. But the clinical reality is that sometimes feeding tubes need to vent, and sometimes drainage tubes are used to feed or administer medications. The good news is, whatever the clinical need, there are safe options available. Next slide. So pictured here in this slide are some ENFit compatible options for gastric drainage and venting that I will review individually. And I just want to note that the drainage flow rates are not any different for these ENFit devices as compared to their legacy version. And some of the products that I'm about to mention in the next few slides are really based on personal use and reported clinical experience, and they're not intended to be examples of what is an exhaustive list. They're just examples to share with everyone today to provide available resources and to help with concerns of product and availability. Next slide. So first up is the Salem Sump. Now, Cardinal Health offers a Kangaroo Salem Sump PVC tube that has the ability to decompress or feed with the added safety of ENFit to reduce misconnections. So as I stated, decompression tubes are designed to drain, but at times the clinician may need to administer enteral medications, or they may want to evaluate the patient's tolerance to initial feedings using this decompression tube. There may also be a surgical contraindication to remove this decompression tube past the surgical area and replace it with the feeding tube in the initial post-op period. So this device allows feeding or medication administration through the decompression tube by using that purple ENFit connector pictured at the top, and it can be inserted into the drainage end of this tube. But once it's determined that the patient tolerates feedings and it's safe from a surgical standpoint, that they could be converted to an actual ENFit feeding tube, best practice is that they should be changed to an actual feeding tube for ongoing tube feedings. Next slide. This device is a multifunctional port with safe enteral connections. Cardinal Health offers a Kangaroo Salem Sump silicone tube with this multifunctional port and anti-reflux valve. This is an all-in-one enteral system that allows for feeding, medication, irrigation, checking residuals, and suction all through this one closed port. Now, looking at this device on the right of the screen, you can see the purple port clearly is labeled feed and med only. To the left of that is the suction port. And then further at the bottom is where this would be connected to the Salem Sump tube. And the white knobs on the side, those are the toggle selection knobs. And they are rotated such that the blue indicator line on the knob aligns with the white line below each respective port. And this is so the clinician would know if the device is open to the feed med port versus the suction drainage port. So this multifunctional port is not available as a separate item, but it comes integrated with the silicone Salem Sump tube in sizes 10 through 18 French. So this device offers flexibility in using the Salem Sump silicone decompression tube for a variety of indications, including the use of ENFit for feeding or medication administration. Next slide. Now, AMT offers G-tube extension sets for enteral feeding that are ENFit compliant, but they also offer this hybrid G-tube extension set in which the medication port is ENFit, which is that green port to the right, and the drainage port is the funnel-shaped connector. And this supports gastric decompression by gravity or suction via a low-profile button-type G-tube or GJ tube. Now, this extension set is compatible not only with AMT's low-profile G-tube or GJ tube, but it is also compatible with the low-profile Mickey G-tube as well. Next slide. So in addition to these drainage tubes, there are drainage bags. GBUK offers DEHP and latex-free enteral drainage bags in a variety of sizes from 50 to 1,000 ml, and they fit all ENFit compliant tubes. And Cardinal Health is planning to introduce an ENFit compliant gastric drainage bag as well. And you can see here in the picture, the purple connections are the ENFit connections. Next slide, please. And there also are closed venting systems. Avanos offers the FarrowValve system, in which this vented bag allows the escape of gas while also providing a reservoir to retain excess formula that is refluxed up into this closed system. The FarrowValve supports continual decompression of the stomach while allowing the stomach to refill at its own pace. This closed system allows connection to ENFit feeding tubes, as well as a connection to the ENFit feeding administration set, which again is depicted by the purple connectors in that photo. So these are just some options available related to the use of gastric drainage and venting using a feeding or decompression tube. Now you may ask, what about these other tubes or catheters placed as quote unquote gastric tubes? Well, Cynthia will discuss these other tubes in her upcoming section of this presentation. Next slide. Now, I do want to have one cautionary statement that I want to add, and that is about transition adapters, some of which are pictured here at the top. And these basically are adapters that would connect the ENFit feeding set or an ENFit syringe to a legacy feeding tube. And due to their funnel-shaped design, these transition adapters still pose a risk to misconnection to a non-enteral device. So it is very important to understand that these are temporary connectors or adapters meant to only be used while one is transitioning their facility to ENFit. But once a healthcare system is fully converted, there would not be a routine need for these adapters, except in the scenario of a patient admitted with a legacy device that for some clinical reason could not be exchanged to an ENFit compliant device. But once legacy feeding tubes are no longer manufactured, there will no longer be a need for these adapters at all. So it's very important that healthcare systems, when planning their conversion, also develop a planned timeline to discontinue the routine use of these adapters. Next slide.
Thank you, Barb. We'd now like to introduce Brittany Dietrich, an enteral feeding patient.
Thank you, Natalie. And I love hearing from Barb, who is a nurse who actually manages these, but I also thought it was super important to hear from a patient and someone who has experience venting and draining with these, and that is me. I have been on enteral feeds and have had tubes since 2015, 2016, but until this year only use them for feeding and now also have a G-tube for venting and draining. And so I wanted to just take a couple of minutes to talk about my personal experience with that and also bust a couple of myths that I've personally been asked or dealt with. The first being is that when I was on legacy and first started with that, just like with feeding, with venting and draining, they do come apart. And just like spilling formula all over the place or feeding the bed, I would vent or drain all over the bed or clothing or backpack or whatever I was connected to if that popped apart. So ever since switching to ENFit, that is no longer an issue for me. I can manage my tube feeds and venting and draining out in public, at work, and just doing normal life. And have found that that works so much better for me, because just like getting formula on things, I'm not getting stomach acid or formula or any kind of spillage or air on anything other than inside that tube or inside those feral bags or other things that I have used. The other positive with using ENFit is that I no longer have to use any kind of connector. So this eliminates using small pieces like AMT clamps or tape or gauze or anything else that could prevent that from popping off. It's just one simple piece. I also love this as I work with small children, and I never have to worry about anything that I am using being a choking hazard or anything that anyone can put in their mouth or lose somewhere on the floor. So that's just been a super positive thing, switching over from legacy into ENFit. Next slide. And then the last thing is that people like to say, or what I have personally heard, is that when you have a button and you use those ENFit extensions, that they're not good for venting or draining because they are too small. And whether it is legacy or ENFit, I have found all across the board, doesn't matter the brand, whether it's the propriety connector or the bayonet or whatever that's called between the two brands, are exactly the same size, whether it's legacy or ENFit. So I have found that no matter what extension I'm using or what brand I am using for my button, they both vent and drain perfectly fine. So yeah, with my personal experience, ENFit has been life-changing for the better. And that's it.
So in conclusion, truth number 2, the ENFit's design does allow for proper venting and draining that is needed to fully convert facilities. And ENFit not only supports, but has improved the venting and drainage experience for the home feeding consumer.
Thank you, Barb and Brittany. I'd now like to introduce Dr. Ruba Abdelhadi, Director, Nutrition Support at Kansas City's Children's Mercy Hospital.
Thank you very much. I appreciate the opportunity to participate. Next slide, please. So I'm going to talk about myth number 3. And myth number 3 says, ENFit smooth design makes it hard to clean and creates unacceptable levels of bacteria. Next, please. Next slide, please. So GETSA and others have developed job-specific sets of specific brushes and training materials to help hospitals with the transition. Standard cleaning materials like Kim wipes and common brushes can also be used. Based on our experience in the US and around the world, hospital staff are readily able to adapt to the cleaning process and ensure residual is removed and the tubes are safe to use. Next, please. Now, because the previous legacy products had no published cleaning standards, we needed to develop a cleaning protocol. And I was actually very fortunate to be one of the clinicians who conducted the cleaning study. We published our study in the Journal of Med-Surg Nursing. We consulted with the infection prevention staff at our hospital. We also consulted with FDA and GETSA and nutrition support clinicians. We designed the process of cleaning with the intent to remove any visible residual. This would be typically either a liquid medication or enteral formula until the item is deemed safe for use. We did not want to use any cleaning agents or chemicals because we did not want any of these to enter into the tube or into the patient inadvertently. And therefore, we needed to use water for the cleaning. We wanted the cleaning procedure to be able to reach all of the soiled parts of the device. In this situation, as you know, the ENFit design has the internal threads. And so we needed a brush to be able to reach these internal threads, especially when there is dried up residue in there. So our cleaning regimen was designed and was validated. We used pulse flushing procedure to clean the moat with water before using the brush. And then vigorous rotation of the brush in the moat and repetition of the cycle based on the visual assessment of the ENFit connector. And so the pulse flushing or the intermittent vigorous water delivery into the moat of the connector using a syringe serves as a method to soften the dried up residue. The cleaning regimen was validated. The testing soil that we used was visible chocolate flavored enteral formula. We instilled it into the connection. We left it for a few hours to simulate the typical time of an intermittent feeding schedule. And we found that either one of them, whether you use the ENFit commercial cleaning brush or the firm bristle toothbrush, either one is effective in removing visible and non-visible residue. We used for non-visible residue a Dazo product, which is an environmental gel that is only visible with UV light. So the learning points out of that, when you see the ENFit connector with visible dried up residue, this will present a challenge when attempting to open the cap because the dried up residue is going to cause the cap to stick to the moat. This emphasizes the importance of cleaning the cap and removing the residue before it dries up. And also, the residue would be more effectively removed if you have water pulse flushed into the moat in order to soften the debris. Whichever brush you use is perfectly effective. The brush would clean the products more effectively when the bristles are wet. You would use the stem of a cotton tip applicator to occlude the opening of the center of the moat to prevent any residual from entering into the lumen of the tube if it's an indwelling tube such as the nasogastric tube or a transpyloric tube. The pulse flushing can be applicable to a low profile extension set. You want to make sure that you tap off any excess water out of the moat. If you're dealing with an extension tubing, you would leave it to air dry. You would leave the moat uncapped and let it air dry because you don't want to leave any opportunity for any like growth in a closed environment with moisture present. If you're not able to let it air dry, you would use a gauze to dry it up before closing the connection. The cleaning regimen was published, it was validated. We used 2 individual cleaning regimens. We used 2 testing soils with the visual inspection of the device before and after the cleaning. And so the staff who participated in this study, they were perfectly able to follow the sequence of the cleaning steps, and they were readily able to adapt to the cleaning process. Next, please. And so in conclusion, our Children's Mercy Hospital developed and tested the ENFit cleaning protocol. And this forms the basis of the ENFit instructions that are depicted in the previous slide. And in addition, to reassure you, this data was submitted to the FDA as part of the normal product review process. And the FDA specifically instructed the Children's Mercy to not include bioburden testing in the review process. This is that the GI tract standard is not sterile. And so the relevant standard under the FDA guidelines is cleanliness, roughly equivalent to dishwashing and not sterility. Next, please. And so truth number 3, the ENFit moat is no more difficult to clean than any other. And with the tested and proven cleaning procedures and tools, you can ensure that the ENFit is ready to use and that the residual is all removed. Thank you.
Thank you, Ruba. We'd now like to introduce Cynthia Reddick, registered dietitian and national tube feeding manager at Quorum and CVS Specialty Infusion Services.
Thank you, and thank you for having me today. I'm delighted to be here, and I feel like my colleagues and Brittany have teed me up perfectly to share the home care perspective, and that's what I'm going to dive into here. My experience in home care started in 1999, and my experience with Quorum began almost 15 years ago. So I've been working with Quorum's home tube feeding population for that time. And we began servicing ENFit patient supplies over 4 years ago. So we have some experience with that. And my goal here is to share some of that with you. So myth number 4, ENFit doesn't meet the needs of the home feeding community because the connectors have a narrower opening that slows feeding. So on the next slide, I'm going to share a little bit of research that was performed, and then I'm going to go into some personal experience. So the Mayo Clinic, there's a couple studies referenced here, and there's references on the slide for you, but the Mayo Clinic studied a couple different approaches. One was syringe compression force as well as gravity feed flow rates. And when they compared legacy feeding tubes with ENFit feeding tubes, which when they were designed, when ENFit feeding tubes were designed, the internal diameter was designed to be the same as the legacy feeding tubes. And so what they found in their research was that there was no significant difference. In that initial study, there was an anomaly with 14 French tubes, but what they later learned after publication was that the 14 French ENFit tube was an anomaly. It was not an apples to apples tube design and did not have that standard internal diameter that was equivalent. Later studies have shown that there's no significant difference even with 14 French tubes of the equivalent nature. But what they walked away with was understanding other things that were more compelling in terms of flow rates and the need for additional compression force with syringe feed. So number 1 is the blender selection. So rule number 1 for the home blenderized tube feeding community is to have a very high quality blender, and then also adding just a minute longer of blending time can significantly impact the viscosity of that blend and make it more, it flow through easier. And then lastly is the recipe and formula choice. So these 3 things are more compelling in the home blenderized community than whether they're using legacy or ENFit tubes. Then the FDA studied also gravity flow rate, and they compared the flow rates between ENFit and legacy, and there was no strong correlation as it related to formula choice. So what they did find is that on average, a 20-minute feeding increased to a 25-minute feeding. And although 70% of ENFit devices had a little lower flow rate than the legacy counterpart, only a third of those, or less than a third of those, actually was a noticeable increase. They also found that there was no increase in tube clog frequency. On the next slide, I want to talk a little bit about what Brittany teed up for me is called feeding the bed. So this is a term that we use when there's an unintended disconnection. It goes unnoticed many times in nocturnal tube feeds, or if it's in the hospital setting, it's when nursing is not around and does not observe the disconnection. And so instead of feeding our patient, we wind up feeding their bed. And so what Brittany talked about was that legacy connection can pop out. And I've seen it occur with just gastric pressure that builds. If a patient's laughing or coughing or moving around, then that disconnection can occur. And so those connections in home care, we have to have a wide variety of adapters and devices that help keep things connected with legacy connections. And so sometimes it requires things like an AMT clamp or extra tape to secure that connection. And in fact, I had a patient that I was working with who was refilling, because we refill a monthly supply at a time at home. And this patient was ordering 10 rolls of tape. And that's because she was taping together her connection 5 times a day and then having to untape it 5 times a day for the 5 feedings that she was doing. So we were able to resolve that quality of life issue, because that's a huge quality of life issue to have to use that much tape, by switching the extension set over to an ENFit extension for a secure connection. So those ENFit connections are more secure. They reduce or eliminate the accidental disconnection, whether it's with feeding or with venting and draining like Brittany talked about. On the next slide, I want to talk about something else that is a problem for us in home care. So rule number 1 in home care is when we're bringing people home on their enteral feeding is we need to make sure our stuff connects to their stuff, right? So that our supplies will connect to their access device. And sometimes it's a bit of a scavenger hunt and a little bit of a fire drill to figure out what devices are needed in order to make sure that they can connect to either a feeding bag or the syringes. Sometimes the wrong types of syringes get sent out because we're unaware of some of these tube types. I'll call them feeding tubes, but they're not really feeding tubes. So let's talk about the first example, which I see a lot of. The red tube, this is actually not a feeding tube. This is a urinary drainage catheter called the Red Robin catheter. And these are very popular, it seems, and this is across the country, not in one specific area, but these tend to be very popular with thoracic surgeons who place them as J tubes after procedures such as an esophagectomy is a good example. And so this tube does not have a balloon to keep it in place. This one is stitched in at the abdomen, and that's what keeps it in place. So that problem number one is that it's not a great quality of life for a patient to have this tube stitched to their abdomen. And then there's also no port on the end of it. So what you're looking at, the red piece is just an open port, but if they don't have what's called a cath plug, which is the little white piece that plugs into that, then they have no way to close the tube. So it's not a great choice and it's not very home care friendly for patients. So this is one example of something that we see out in the wild, so to speak. And then the second picture with the blue tube, this is a drainage catheter that has been, again, stitched in. This is a pigtail style tube. It's actually a drainage catheter that got stitched in. And when you look at the doctor's procedure report, it's dictated as a multi-purpose enteral feeding tube. And it's actually not a multi-purpose enteral feeding tube, it's a multi-purpose drainage catheter. And the problem with this tube, aside from having to have it stitched to the patient's abdomen, is that it has non-enteral friendly connections. So there's a tube with a switch adapter on top of another adapter that then connects it and makes it into a legacy port. So it's tube and adapter on top of extension. So these are the things that have to sort of get pieced together so that a patient can successfully feed at home, because this is the device that was selected for them. So for the clinicians on the call that are working in hospitals, the ask is that you advocate for what would be a portable tube, meaning there's portability. They can move from hospital to hospital. They can move from community to community, state to state, country to country, and have the same enteral connection. That is a universal connection that is dedicated just to enteral because of the problems that these devices cause when they're chosen for enteral feeding tubes. So in home care, ENFit is a beautiful thing, not only because of safety, but because of these exact reasons, portability and standardizing that connection. Now on the next slide, I want to share a little bit of the home care perspective. So this is our patient population. This is Quorum's ENFit patient population. And I thought, well, let's look at what types of formulas are being fed through the ENFit devices that they're using. And so I decided to break it down by sort of viscosity or formula type. So in the light green, most of the patients are either on somewhere between a 1.0 and a 1.5 calories per milliliter density. So that's either a standard or peptide. And then 21% are powdered formula of one form or another. Many of those are ENFit formulas. About 6% are 2 calorie per ml, so it's a little bit denser formulation. And then 4% have a commercially prepared blenderized tube feeding. So I thought this was interesting. These patients are successfully feeding at home with their ENFit devices. And then lastly, on the next slide, I thought I would share, this is just a glance at a subset of patients that are ENFit. And I thought, well, let's look at what kind of tube type they have. So these are patients that I could get current, accurate device data on. And you can see that 2/3 have a long-term access device and about 1/3 have a short-term tube. So a long-term tube being a surgically placed tube. So more than half are gastric, 4% GJ, 9% jejunal. And then you can see in the short term that the nasogastric tubes are about a quarter of that population, and then nasojejunal is about 7%. So lastly, let's talk about our truth on the next slide. So what I can tell you is that from experience with thousands of patients using ENFit devices over many years, ENFit meets the needs of the home feeding community while also preventing disconnections and avoiding feeding the bed.
Thank you, not Brittany, sorry. Thank you, Cynthia. Now I'd like to introduce Mike Cusack, Executive Director of GEDSA again.
Thank you, Natalie. And Natalie, just to confirm, my myth number 5 is showing, correct?
Correct.
Okay, thank you. So let's talk about myth number 5, and that seems to be a fairly common one. What the perception is that ENFit doesn't really fix the problem of misconnections. And on the face of it, as that statement is written, that's true. But ENFit was never intended to solve the problem of misconnections. It was intended to be part of the solution. I'm going to talk a little bit about the solution in the long run and how ENFit fits into the overall scheme of things so that you understand how it goes about solving a portion of the problem. ISO 80369 is an engineering-driven approach that was created to eliminate as much as humanly possible human error from misconnections. So it's similar to the approaches that people have taken in aerospace, nuclear power, or surgery. And that is that there should be multiple interlocking approaches to safety. It's not just one aspect. It's a systematized, network-driven type of approach. So the ISO standards were designed to minimize the opportunity for this human error by making it as difficult as possible to create a misconnection. So no system is perfect, as we all know, and human error may still occur, but the ISO standards drive the possibility as low as possible. So if you think of it kind of like automobiles, automobiles have a system of interconnected safety systems. They have turn signals, there's ABS, there's look-ahead vision, there's rear cameras, blind spot detection. All of these were created to help the driver minimize as much as possible any opportunity for a mistake to happen. Next slide, please. So here you see a family of lure connectors, and that's precisely how we got here, because the lure connector was and is very successful. It's high quality, it's secure, it's easy to manufacture, it's easy to use. However, because of those positive attributes, its success became an Achilles heel. So as more and more therapies came into the hospital, relying on minimally invasive access, the lure connector was the de facto standard that manufacturers chose. And as these therapies proliferated, more and more lure connectors were in the market, and the possibility rose dramatically for misconnections because all the lure connectors are compatible one with another, even though the therapies behind the connectors may not be. Next slide, please. So here you see a list of ECRI's top 10 technology hazards from 2012. That's the Emergency Care Research Institute. And midway down the page, highlighted, you can see inattention to change management for medical device connectivity, and specifically called out enteral feeding misconnections. So ECRI published this as part of its study of the top 10 technology hazards found in hospitals. So that was one contributing factor to the rise in concern for these misconnections. A year or two earlier, Deborah Simmons et al. In a 2010 literature review found 116 cases of misconnections. And if you take a moment to look at them, you'll see that nearly 20% of these cases resulted in death. And just to give you a comparator, that's a mortality rate that's similar to typhoid or SARS. So it's not an insignificant problem, wasn't an insignificant problem. And one last caution here, keep in mind that most of these errors go unreported or underreported. So you're looking at the tip of the iceberg here. So this is another contributing factor to concern over the widespread use of lures and what could be done about it. Next slide, please. When you look a little bit closer at some of these misconnection adverse events, and I'm not going to read this entire slide to you, but I've highlighted the specific misconnection there in bold. And with the exception of the first patient, all the rest of these resulted in death. I'm going to give you a moment, particularly look at the last one, where a mother and her 35-week old fetus, neither the mom nor the fetus survived after being misconnected to an enteral feeding solution. And a videotape of that woman's name is Robin. A videotape of Robin's mom talking about that situation is available on our website. Now, the first reported case of misconnection was in 1972 in the Lancet. So it's a British medical journal. This problem goes back for some ways. So since then, there's been this steady stream, low volume, but catastrophic often in nature, of misconnection events. So what was the result of that? Well, next slide, please. The International Standards Organization, often referred to as ISO, decided to convene a series of meetings among technical experts, regulatory and standards experts, as well as clinical experts, to come up with a scheme to minimize the possibility of these misconnections when using small bore connectors. So these groups all met over the course of a year or so to establish unique design standards for each clinical application so that tubing from one application was incompatible with another. So think of it like a therapy-specific silo. The connectors for enteral feeding will only connect within that family, and the connectors, for example, respiratory, would only connect within that family, making a cross-connection as physically difficult as possible to accomplish. Next slide, please. So if you look at the big picture, recall I said that the statement as written on the face, the misperception that ENFit is not the solution. It is not the solution. It is part of the solution. When all of these connectors are put in place, then we'll have the complete solution available. So this family of connectors, the two that are on the market right now are ENFit, that's enteral, which is referred to oftentimes as -3, neuraxial, which is there referred to as -6. Those two are on the market. In fact, Japan has already converted to the neuraxial connector and is in the process of converting to the enteral feeding connector. But so what are the unique characteristics that make this approach doable? First, I mentioned that the connectors were not compatible with connectors from other therapy areas. So they're dedicated to their silo, but they're not cross-connectable. They're rigid or semi-rigid in nature. That means that you can't just force fit them one into the other. They don't conform. They're stiff. They also were required to pass a pretty rigorous series of testing, misconnection, risk analysis, usability, and human factors testing, all of which was required by the FDA and is on file with them for GEDSA members to refer to when getting devices approved. And they are also incompatible or not connectable with Lure or needleless connector reports. So when all of these are in place, you'll have an umbrella of protection that will exist. So think of it, if you go out in the rain with an umbrella, only one pane existing, your shoulder might be protected, the rest of you gets wet. You only stay out of the rain when your umbrella has all the panes in it, and that's exactly where we're going with this family of connectors. We have two panes in the shield of protection that's available. That's the ENFit connector for the regional anesthesia, and for several years now, ENFit's been available in the market. The respiratory standard, I think I mentioned earlier, the standard was approved. That's the next one that's been teed up. There'll be one for limb cuff, and then eventually the Lure connector will be dedicated to IV or hypodermic usage only. Next slide, please. And Natalie, just to confirm, this is my regulatory support slide?
Yes.
Okay, thank you. So Cynthia mentioned earlier, as well as Dr. Abdelhadi, that the FDA has been involved in this effort from the very beginning. In September of 2018, the FDA sent out a letter to 4 groups, manufacturers, of course, hospitals, patients, and supply chain and logistics folks. And the FDA recommends that hospitals and clinicians use enteral devices with connectors that meet the ISO standard and or designed to reduce the misconnections. So that's the most recent FDA communication. The Joint Commission Physician Leaders Network sent out 2 emails to 4,000 leading doctors. The Joint Commission followed suit and supported the FDA's effort to encourage the adoption of ENFit. CMS, the Centers for Medical Services, in its Sentinel Alert number 53, echoed the Joint Commission statement as well as the FDA statement. Aspen itself, that Chris mentioned earlier, that's our clinical society, it supports the use of ENFit. So you have a concerted effort led by the manufacturers and supported by the regulatory and clinical folks to introduce this series of protective connectors so that we can eliminate as much as we can the possibility for enteral feeding cross connections, or for that matter, as other connectors come into the market, any type of misconnection using a small bore connector. And I'll stop there. Thank you.
Maybe we can go back one slide. I'd just like to read out Mike's truth is that ENFit is one connector out of a family of connectors that, when completely converted to, will prevent small bore misconnections. All right.
Sorry about that, Natalie.
You're fine, Mike. And now we'd like to introduce Ben Davis, an expert in enteral device engineering and product development.
Thanks, Natalie. I'm here to talk about myth number 6, but before I get into myth number 6, I did want to share just an additional piece of information on the misconnections that Mike was just talking about. The true, to have a comprehensive misconnection solution across all areas of therapy for these small bore connectors, you really need every pane of that umbrella needs to be in place. And so that's hopefully the future state, is that the other sections of the standard are put out there and then followed. However, ENFit, the -3 section of the standard, was comprehensively tested for misconnections among pretty much really all known small bore connectors that meet the definition. So, and it resolves those misconnections, and that was about 400 pages of misconnection risk assessment. I think it was like 450. So it actually, within the enteral space, I would say it does resolve that misconnection potential. I just wanted to clarify that in case anyone was sort of missed that point. But anyways, but that's the technical side of me. I just can't get away from it. So back to the ENFit solution. ENFit is myth number 6. ENFit is a solution in search of a problem so that manufacturers can profit. Next slide. So, and Mike really just went through some of this as part of the genesis of the, how did this standard come about? So I won't beat this to death, but really it did, I think it really all sort of started back in 2006 with a Joint Commission issued a Sentinel event alert on tubing misconnections. And then around that time or shortly thereafter, inside of the ISO sort of process, you have different technical committees. And within Technical Committee 210, which covers these types of devices, a working group was actually established. And that ended up resulting in the ISO 80369 series of standards. And within this effort, that's actually clinical folks. You have technical and regulatory experts. Manufacturers are part of the process, but they're not the only part of the process. And this is all within the framework of the International Organization for Standardization. So really, just to be clear, this is not. If the perception is that this was, manufacturers somehow all got in cahoots together behind closed doors to come up with a scheme to increase prices, that's simply not how this went or how this was started, initiated, and how it was led and executed. Next slide. So let's look at what ENFit, the realization of ENFit actually means for manufacturers. It really means actually a lot of costs. So you have R&D costs, and keep in mind this is not just one product. So you got these big medical device companies, maybe within a product sector, they do good to release some new technology every, maybe every year or two they come out with a new product that you see. This is not one new product. This was entire portfolios of products, because this is all of your enteral products. So this is a huge R&D undertaking. You have engineering time, product development time. Within the engineering process, you have to do performance verification of all your products. You have to do usability and validation with actual users. You have intellectual property concerns, and there's a lot, anytime you get lawyers involved with anything, you have a ton of cost. And there's even small things that and I'm trying to give everyone a peek behind the curtain here. There's even things that you just wouldn't really think of, most people wouldn't. Things such as like syringe pump characterization. So if you sell syringes and you're now coming out with a new syringe line, you have to go through the process of having that characterized or basically validated on all the different syringe pumps that are out there that you want to be in use with your syringes. So even stuff like that is a huge undertaking that most people probably don't consider or know that it's part of this process and cost. You also have regulatory costs, and that can include things like not just the 510K, FDA 510K submission costs, but actually assembly of that packet. I mean, there's usually hundreds of pages, and every one of them is a relevant piece of information the FDA needs, and it's extremely robust and very time consuming to put all this together. You have the master file process where a lot of the, as Mike mentioned, the misconnection risk assessment data is maintained. And you have to actually, if you're wanting to launch an ENFit product or ISO 8669-3 product, you would be best to probably buy into the master file because it's an easier pathway or better pathway. But that comes at a significant cost. And then there's also part of the regulatory cost is some remediation that has to be done. If you're a device manufacturer and say you get your 510K for your product, 20, 25 years ago, and now you're updating or have to submit a new 510K because you have a new connector. Well, a lot of times the FDA is going to want you to bring your old submission, which is still valid. They want it to bring it up to the current state of the art. So it's not just as simple as a simple device filing that's sort of an extension of a product that you already have, which can be, easier, relatively easier. A lot of times it's very labor intensive because it's essentially a whole new filing and tons of remediation work, and just a lot of time and money goes into it. Next slide, please. The other huge cost for manufacturers are your new tools. Most your products in this space are going to be plastic, disposable products that are injection molded. So for instance, like syringe barrels. Here's 10 different sizes of syringes, and there's actually even more, but this is an example like of one manufacturer that has 10 different offerings. Every one of these has to have a new tool built to have an ENFit connector on it. And these tools, depending on the manufacturer and their capabilities and the complexity and cavitation of the tools, usually for a syringe tool, you're looking at probably $75,000 to $750,000 for each tool. And again, that has to be done for every syringe barrel size. You have other things you have to make new tools for, such as your tip caps now have to be different. The tip caps for your syringes. You have the male tubing connectors, and these connectors actually also have closures. In that space, you also have dual port connectors that have to be tooled up. Then you have the female tubing connector, and you have the closures that go on those connectors also have to be tooled. And then you also have all the relevant accessories you need, such as tamper-evident syringe caps. There are oral administration products that have to be tooled. You have medication bottle adapters. Those come in, to my knowledge, 4 different types, and each of those has multiple sizes that are available. So you're probably looking at 16 plus tools right there just for those accessory products. And you have other things like female adapters, milk transfer lids, and specialized cleaning tools. All these cost money to tool up, and it's a significant amount of money for each one. Next slide, please. Then there's also the increased manufacturing capacity costs. So with all these new tools, you often have to get new injection molding machines. You have to sometimes get additional print capacity or set up additional print lines. And then you may have to increase your tubing extrusion capacity. So tubes are extruded, and if you're now carrying 2 lines, it's not as simple as just having, demand, let's say demand stays the same. Well, when you go from 1 line to 2 lines, you actually have to then carry more inventory because of the variability among both lines. So all your stuff kind of goes up because you complicate things by having the 2 lines. So yes, the demand's the same, but you're actually carrying more product. You also have to then have parallel packaging lines and parallel packaging materials. These are all labeled different, and most of these products come with multiple layers of packaging materials. You got the outer box, the inner box, and then the peel pouch or whatever the individual package is for that product. Those are all different, labeled differently. You may have to even add sterilization capacity. So if you're, like I just said, if now you're carrying these dual product lines, it may mean that you're having to carry additional sterilization capacity to have the same throughput or the needed throughput, the increased throughput that you need. And then you have to have increased clean room manufacturing space to then fit all this stuff in. And of course, clean rooms and manufacturing space in general just are not cheap either. And then on the other side of this, once products are done, you have to have increased warehousing and logistical space and costs are associated with it. You now have to warehouse this additional product. And of course, now you're shipping more. So really all throughout the supply chain, you're carrying more product, and that all has costs. And then finally, you have associated business costs. So you have to do the marketing of these new products. You have to do all the training of the sales reps. And then you have just basically your administrative and just costs, et cetera, costs like that as well. They're all part of the business of really a new product and launching a whole new portfolio. So really the point of these 3 slides here about costs is that, you see all this cost, and it's a lot. And I could go on for days about and dive deeper into all these, but it's a lot of cost to bring any product to market, let alone an entire portfolio. But what should be noted is that despite all these costs, I think if you were to look across the product offerings that are out there, you've probably not actually seen a significant or even a notable uptick in product cost. Now, maybe from manufacturer A to manufacturer B, and A was legacy and B is now ENFit, there may be a difference because it's different manufacturers. But if you look at a manufacturer that does both, I doubt you've seen really an uptick in any of the costs. The space remains very competitive. And in fact, I think because of the standardization, you actually have new manufacturers in the space that have actually made it even more competitive. So companies that weren't out there before ENFit now exist and are making products. So I think it's probably even become more cost competitive. Next slide, please. That brings us to the truth for myth number 6, which is that ENFit is a patient safety initiative that was born from the clinical community and is spearheaded by clinical, technical, and regulatory experts and their manufacturers all within the framework of the ISO process. There are actually enormous costs that are associated with this initiative, yet there's not really been a noted uptick in product pricing. So despite what the myth says, this is not some ploy to do a whole bunch of work to then try to increase profit. It was not a profit-driven initiative at all. It was a patient safety-driven initiative. Thank you.
Thank you, Ben, and thank you to all our speakers. We are now going to move into the question and answer part of the segment. As I said and mentioned in the chat, if you submit a question in the Q&A instead of the actual chat function, we're more likely to get to it. So we've got quite a few in there. We're gonna go through them. And if we do not get to your question, we will be sending out responses after the webinar to make sure we cover any questions we miss. So I'm gonna go ahead and read through these, and we are going to ask our speakers, whoever feels most like it's part of their segment or would like to answer, we'll go ahead and take the question. All right, the first one is on multifunction port. How do you tell if the anti-flux valve is activated successfully or deactivated? When we activate it with 10 to 15 ml of air, you cannot tell it is active or not. Barb, I believe you may want to take this question.
Yes, thanks. Yes, that's a great question. You are correct. The person who posed that question, there's no indicator to say that it is engaged, if you will, but this anti-reflux valve, it really requires a reset of the air buffer after every flush of water or saline. And so it's important to make that a common practice that after injecting water and saline through that anti-reflux valve port, that it's followed with 10 to 20 cc's of air, and that will prevent gastric leakage. But you are correct, there's no indicator to say that it's working. I think the indicator is whether you have gastric contents leaking through that ARV port in the front or not. And it's important to use a cath tip syringe when injecting that saline or water. That's the only type of syringe that would fit that ARV port. And then if I may, there was another related question about frequency of changing this. This multifunctional port with the ENFit connection only comes with the silicone tube. And silicone tubes generally are changed every 30 days. They're considered a longer term dwell tube. So that's a guideline to consider, but there's really no recommendations from the manufacturer. The company does sell the non-ENFit version of these multifunctional port individually, but at least in my Midwestern experience, I have not been able to purchase the multifunctional port with the ENFit connection individually.
Thank you, Barb. On to the next question. This one's long and I will open it up at the end. So our institution held off on the system-wide implementation of ENFit device because of BD's future rollout of a solution. I may be incorrect, but I have not seen a solution to date, and BD ended up scrapping their original design anyways. For those who don't know, this is RightFit. Not sure if this information is to be discussed during the session, but any word on where BD stands? This question affects BD heavy hospitals and puts us in limbo to use connectors, adapters, which are a risk, as we know. Now, I would like to open this up to Ben Davis as well as Mike. I know that you'll probably have some feedback and I can provide some light if needed.
Mike, you want to speak to that, or and maybe I'll chime in?
Yeah, that's fine, Ben. So the questioner is correct. BD did abandon that effort some time ago. I have the letter from BD. I can make it available to folks. But BD decided not to pursue RightFit and is currently, through its Bard subsidiary, selling ENFit compatible devices. So I would say that now the ENFit, or sorry, the Becton Dickinson's RightFit is not going to see the light of day on the market.
Thank you, Mike.
Yeah,
Do you have anything to add?
Yeah, I have nothing really to add except for the BD did send out a formal letter, and it's, I think, still probably available on their website, but it was summer of 2020, I believe, that went out, basically stating they were no longer pursuing that proprietary integral connector they were developing.
Yeah, Ben, you reminded me of something. I do know, too, that Becton Dickinson is a supporter in general of the ISO 80369 series and is actively pursuing the introduction of an NRFit, or regional anesthesia connector. So Becton Dickinson overall supports the move towards safer connectors.
Thank you, Mike, and thank you, Ben. On to this question. Barb, you may have answered this. How often does the multifunctional port device need to be changed out? Can you remind me that was answered already?
Yes, that was answered. Given it comes with a silicone tube, that's traditionally a 30-day longer dwell tube, changing it with the tube would be indicated.
Okay, perfect. Thank you. Have you, it looks like Cynthia actually might be typing an answer to this right now. Have you seen supply chain delays affect ENFit rollouts to cause shortages in ENFit components? I'll actually open this up to any of our speakers.
Yeah, this
So
is
Natalie,
something
this
that
is
crosses all of us, I think. So I think Brittany may have an answer. I can speak to the home care perspective, and then there's hospital supply chain as well. So I can say in general for enteral supplies overall, we've had a variety and always have a variety of back orders here and there. So our approach in home care at Quorum is to have duplication. And we have found that there's enough duplication with ENFit supplies, like Ben alluded to, that we have not had any issues being able to provide ENFit syringes or extension sets or balloon replacement tubes. So we have had no issues that way as it relates to home care provision.
This is Barb. I could add too on the hospital side, certainly all the supply chain issues in general we're all experiencing. We have substituted in other brands of ENFit, but we have not had a situation where we were without an ENFit syringe, feeding tube, administration set.
Yeah,
But
this
like-
is Brittany, and I can agree with both Cynthia and this is Barb, right?
Yes.
Yeah, I have had both home care and inpatient within the last year, where if something wasn't available, it was replaced by something else, but the outcome was the same, whether it was something that I was used to or something new, or it was just a different brand. If there was ever a back order, or, you know, my small town hospital just didn't have something, I was always given a solution. There was always something, whether or not they had a specific item or not.
This is Chris from the pharmacy side. So I think we've definitely seen some things where one manufacturer wasn't available, but someone else was. But I think where some of this is coming from is early adopters. So folks who went live 2, 3, 4, 5 years ago, it was much more common, but the market's become much more robust since then. So I think if you did searches, if you heard from people's experiences, this definitely was a concern, but I think it's more historic, other than the current supply chain issues kind of across the board, not specific to either ENFit or hospitals or anything along those lines.
All right, and Mike, did you have one final comment?
I did, but everybody covered everything, so I'm in full agreement with what's been said.
All right, thank you, everyone. On to the next question. So, in the spirit of the webinar and for transparency, please clarify the myth that all companies have stopped manufacturing legacy products as of July 2021, because they have not. Mike, I believe you can shed some light on this, and then we can open it up to anyone else on the panel.
Sure. Thanks, Natalie. So the GEDSA members, which is not the entire industry, but a substantial portion of the industry, GEDSA members have agreed to phase out production according to each individual member's business goals and manufacturing capabilities. The questioner, the statement that all manufacturers have not phased out legacy devices is true, because there are several companies that are not part of GEDSA, and they've elected to continue manufacturing legacy devices. However, with GEDSA being the lion's share of the market, and by that I mean probably in excess of 80%, it's foreseeable that the market will convert over the period of time, next several quarters, to ENFit connectors. That's not to say that there won't be legacy devices available. However, recall during my presentation that all the major regulatory and clinical groups are lined up behind safer connectors as represented by ISO 80369. The brand ENFit meets all of those. I don't know if other manufacturers are going to introduce their own connectors. Probably not at this point, but that statement from that questioner is true, and it's likely to continue for the near future.
Thank you, Mike. And you may have said this, but we just also like to reiterate that production is different than actually stopping selling supplies. So production is to have stopped, but selling will happen until they run out.
Thank you, Natalie.
I'll just add to that and say, that having been involved with supply chain before, I mean, on some products you may have 30-day supply, or 45 days may be your safety stock metric on like a real high volume product. But then, there are other products that you may, based on minimum order quantities, a minimum order for a manufacturer, the plant may represent like 3 years worth of inventory. So, you're going to have, across all these different products, you're going to have different sort of wind down dates. And, it's not, I don't think, reasonable to just burn up all, just sort of dispose of all that inventory and eat all that cost. So, I think most manufacturers are probably going to try to wind down their stocks. And like I said, it could be a short supply in some places, and then on other products, it could be, months and months and months out, just depending on how much stock they had when production stopped.
Thanks, Ben.
Thank you, Ben. All right, a new question. Do you know if retail pharmacies will begin to stock ENFit syringes for medications? I know this is out of your control, but do you have any insight about this? Mike, would you like to answer this one?
Sure. I have reached out to all of the major retail pharmacy chains outlining this situation and offering our help to make it happen. I've heard back. It's not a major priority for any of the chains right now because it's late in the year. There's COVID. There's a variety of factors depending on which which retail pharmacy you're talking about. However, based on the feedback I've gotten, I believe that the retail pharmacies are aware of this on a national level and will work with us to make the change necessary for patients to be able to get over-the-counter syringes through their local pharmacies. But it's not something that will happen overnight for a variety of reasons. You know, Ben talked about some of them in terms of manufacturing and inventory and quality, all that. But I'm 100% confident that it will happen.
Thank you, Mike. All right, we have another question. Is GEDSA planning on publishing the low-dose tip syringe accuracy data? There is published peer-reviewed data showing they are not as accurate as legacy syringes with sound methodology. Publishing GEDSA's data and the methods behind testing would be beneficial. It is hard to refute published data with the limited explanation on accuracy provided in this presentation. This may be a Mike and Ben duo question. I know that you both have some insight on this.
Sure, I'll let Ben go first. He's our technical expert, and then I can chime in.
Thanks, Mike and Natalie. Yeah, so GEDSA has tried to succinctly sort of summarize this data in a poster that's on the website. Because I think it really boils down an immense amount of information as succinctly as possible. Because as we set out to test this plus minus 10% accuracy metric when giving a 0.2 ml dose in a 1 ml syringe, really the best way that it was agreed to test this was you'd have to benchmark it against legacy products of various different types, because you can test and develop data all day, but when there's nothing to compare it to, you know, what does that data actually mean? So that's why we actually bench tested against these other products. As far as other peer-reviewed stuff that's out there that says, I guess you're saying has sound methodologies and stuff, I'm aware of some. I've questioned some of the methodologies I've seen. I do think you have to test against or benchmark against other products, and all have to test within the same way. The members of GEDSA and members of its technical committee that work through the low-dose tip testing and a third-party lab that actually performed the testing developed an engineering test protocol that was signed off by all the technical experts of the committee. And let me remind you, or inform you if you don't know, that these people actually provided the test syringes. So you have some of these syringes in here, like these these female tip syringes, were actually provided by GEDSA members on the technical committee that signed off on the protocol. Now, I don't think they would want their syringes to test poorly. So I would say it's a fair protocol because it's meant to test across different types of syringes. And comparatively, the data weighs out that low-dose tip is as accurate or actually a little bit more tightly tolerant than even legacy oral syringes and more accurate than other reverse systems that are on the market. Now, Mike, as far as the actual full comprehensive plethora of data in its availability, do you want to speak to aspects of that, or maybe you can also touch on that
Sure.
too?
Yeah, so I'll start out by noting that we GEDSA worked closely with the FDA in an effort to get safer connectors on the market. And the FDA directed us to create what we call the master file archives. There are several of them. There's one specifically related to the low-dose tip, and that was a study that was done. Recall my slide where I listed several of the risk analysis, the FMEA testing, the usability testing. All of that information was directed to be completed by the FDA. We did that as a group. We submitted that to the FDA, and upon their review and acceptance of that file, that allows us, the members of GEDSA, to submit products and refer to that master file archive. So in the eyes of the FDA for the use of product approval, that master file archive basically says those products work as intended when directions are followed. And that's what the industry has used to get these products onto the market. So to the extent that there's data available, there is. The FDA is sitting on a pile of it. Whether or not the public can get access to that, I don't know. I can certainly ask the question of the FDA, but you know, back to what Ben said, we tried to boil down the protocol into something that was generally accepted from a scientific method standpoint and well defined, so that we could, as a group, stand on that data. And that's pretty much all I have to say on that, aside from you know, Ben's comments about the published data. And there have been letters published to the editor questioning the methodology of the studies that were referred to by the questioner.
Thank you, Mike, and thank you, Ben. Moving on to another question that we've received. You mentioned that the FDA's safety communication on the low-dose tip syringes earlier in the presentation. What is GETSA's stance or comments on the letters that the FDA sent to manufacturers to hopefully increase patient safety? I could open that up to Mike, as well as any of the input that we'd want to hear from our speakers on their perspective on the safety alert.
Sure, I can give just kind of an opening statement. First, we're thankful that the FDA received that single complaint and called it to our attention. And what the result was, the FDA focused on the labeling around some of the products, not on the performance. If you read the statement the FDA put out, they continued to encourage the use of the low-dose tip, and they asked manufacturers to beef up, not all manufacturers, some manufacturers, to beef up the labeling so that the instructions for use were more clear. But overall, GETS is happy with the performance of the low-dose tip and thankful for the FDA's oversight.
Thank you, Mike. Do any speakers have comments on the letters for safety or their experience? Not required, but thought I'd ask. Okay. Moving on, so we got a question after Brittany had spoken about possible tangling or tripping on line and breakaways for feeding, long feeding periods with babies and infants. Since Brittany is an adult, Brittany would like to shed some light on her experience because she also has experience with a toddler who is a tubie. Brittany?
Yeah, so I for a while nannied / babysat a tubie, and while it is absolutely a thing to have the tubes kind of, you know, when we would put him on his pump, sometimes, you know, he's a toddler, he's running around, he's playing, he's having a good time, and he does have his tubes trailing behind him. The only light that I can shed on that is that as a caregiver, you just are mindful, you know, just like you would be if a child was playing dress up and their costume was too big, or, you know, any kind of risk that there is with watching a child, is you just keep an eye on it. The tripping on the tubes, if that is an issue, it's going to be an issue whether or not that's ENFit, legacy, you know, any kind of tubing, oxygen, catheters, you know, all that kind of stuff. So usually when it comes to small children, either you have it kind of taped a specific way that works well for you or your child, or you have it in a backpack or things like that. From my personal experience with the toddler, we just kept an eye on him when he was running around and playing during feeds and stuff. You know, we did our best. We used different devices to tape them or clamp them to his clothes. He had a little backpack. And then from a caregiver side, or as a patient side, as an adult working with kids, is that when I'm wearing my pumps and tubes, and whether it's venting, draining, feeding, however I'm using them that day or in that moment, sometimes both, or even sometimes I'm running IVs as well as tube beads at the same time, is I just keep an eye on it, and I stay mindful. And it actually is, you know, I mean, it's just, it goes back to that debunking of, you know, if you're going to be tripping over tubes and stuff, just keep an eye on it. But the positive thing too is that while they're running around and playing, or while I'm running around and playing, depending on, you know, who's wearing what pump at what time, is that the positive look is that ENFit, you know, if I were to snag on something, it's not going to pop off and get feeds or bile, or, you know, whether I'm venting, draining, or infusing, or whether that baby that I was watching was venting or feeding. We're not making bigger messes. There's no formula all around the place. He's not pulling it apart. I'm not pulling it apart. When I accidentally get stuck on things, and it tugs, it's not popping apart. So yeah, it's just, again, keeping an eye out and making sure that, you know, you're just being mindful, knowing that a child or yourself is connected to tubes and you're not going to be tripping over or tangling on them.
Thank you, Brittany.
I'd like to add, if I could, let me just add to that as well. This standard, ISO 8369-3 and ENFit's a connector. The standard is for a connector. So just as with legacy systems, there's nothing within the ENFit or the ISO standard that says you can't have some sort of breakaway mechanism. That would be part of the device itself and not the connector. So if this was a problem, you know, the manufacturer is free to develop a solution for it. If this was submitted through whoever your supplier, if this happens at your facility, then if it was a complaint to the manufacturer, then it would be within their R&D department to address it and see do they need to develop a tubing to address that concern. And I would also say from a nasogastric tube perspective, most tubes in the legacy world, at least to my knowledge, actually have a separation force performance criteria that they have to meet. And I forget what there's, it was EN 1615 and 1618 was the standard. Now it's ISO 2695. Say what that separation force is. There was also internal specifications. Anyway, point being, that force, I would be willing to wager, is probably exceeds the value of what most securement techniques that are out there that I've seen, like taping, at least to like a neonate space for sure. Maybe besides like a brindle or something like that. But I think you're probably gonna be pulling the tube out, even on a legacy tube, if someone trips over it. In a lot of cases, before the tube actually breaks apart, even in the legacy world, at least from what I've seen. But again, bottom line is there's nothing within the standard that says you can't develop some type of breakaway technology if your customers complain or say that they need something like that.
Thank you, Ben. Does anyone else have anything to add? All right, we have time for one more question. I want to make sure I got the wording right because the question was slightly adjusted. So if this is your question, feel free to message us in the chat. An individual in Brazil is in the first steps of ENFit adaption, and they're worried about making the change of enteral tubes. So they wanted to ask, what do we do to implement ENFit connections in the infusion sets without enteral tube modifications? I'm guessing that means some things aren't available at the moment. Do any of our speakers have any details for this one?
This is Barb. I'm not sure if this answers the question. However, I do know early on in 2016, our feeding administration sets were being shipped ENFit with the transition connector attached to them because our feeding tubes were still legacy. And that was that manufacturer's way to ship it, and that you got the transition connector. So if you needed it, you used it. And if you didn't need it because you had ENFit feeding tubes, you removed it and discarded it. So if Brazil is having an issue with, they have legacy feeding tubes, but they're getting ENFit feeding administration sets, it seems to be a timing factor of the types of products that are being supplied, and that they may need to use the transition connector until such time that ENFit feeding tubes are available. So they should probably talk to their feeding administration set company.
Thank you, Barb. Does anyone else have anything to add? All right, I appreciate it. So that will conclude today's webinar. We appreciate and thank everyone that could come and be in attendance. If you do have lingering questions after the webinar, you can always email us at info@gedsa.org and we'll take those questions, we'll answer them. If you want to talk to any of our speakers, we can filter those questions to them and get answers back to you. We also will be providing this webinar and in PowerPoint form and in a recording form later on. It should be about 24-hour turnaround, so keep an eye on your email. Again, thank you, everyone.
Thank you, Natalie.